AI initiatives, what we see, they fail not because of the technology itself, but it fails in the adoption.
Success with AI in the FQHC space hinges.
Welcome to part 5 of the AI and the Safety Net series. In this session, Bill Franz and Andrew Yonke break down why AI initiatives fail and how to build a culture that actually embraces the change.
We see a lot of organizations that try to start with a tool instead of starting really with what problem am I trying to solve?
Why do so many AI initiatives fail, especially sometimes in community health centers?
You need a strong strategy and strong leadership in adopting AI and prioritizing initiatives within the AI realm.
When you see AI really introduced, how is it that people aren't ready for it?
If you don't have a cultural strategy that nips that completely in the bud immediately, then you will likely run into extreme challenges in adopting AI.
How do I know my health center is ready?
What problem are we actually trying to solve? And it can be an efficiency problem, it can be quality of care, it can be a number of things, but we have to ask that question.
The people that you seek to replace are the very ones that actually are the humans that need to remain in the loop to still apply the judgment and authorize the decisions and the courses of action that an AI-driven workflow might seek to make.
Good morning, everyone. Good afternoon. If you're in the on either side of the coast, if you're in the Hawaii Islands or in the Pacific Islands, a very good early morning to everybody. So happy that you're here. Just a little bit of some housekeeping. We are so excited to have you. And before we get started, in your teams that you've just joined, you're going to see kind of some 2 chat options. So if you have any questions for our speakers during the session, just use the Q&A panel. I know we also have a chat panel, and Jessica is graciously going to moderate that for us, but we're recommending that everyone use the Q&A panel. So it kind of just helps keep everything organized. And then we're going to take, questions throughout, but we're going to leave time at the very end to answer as many questions that we can. And then finally, the recording will be shared with attendees after this webinar. So feel free to stay focused, stay engaged, ask questions. You'll be able to share the webinar with other individuals that weren't able to make it today. So we are so happy to have you here. Let me introduce myself. My name is Jen Genoa. I am going to be the moderator. And my background is I've worked in community health centers for over 20 years. 8 as a CEO. I'm also on faculty at the National Association of Community Health Centers, and I work with a wide variety of health centers. I also am contracted with the Bureau of Primary Health Care and do a little work, but I'm really happy to be here and just learning from Andrew and Bill. So really excited. Bill, I'm going to just quickly, if you want to introduce yourself, and then we'll ask Andrew as well.
Yes, my name is Bill Franz. I'm president and founder of THRIVE. We're a small boutique consulting firm that specializes in health centers. We work nationally around the country helping health centers improve their operations, their clinical flows, all things health center related. Our team is primarily made up of former leadership from health centers, including myself. I was part of the leadership team of a health center in Florida. And it's a privilege to be here. And Andrew and RainTech are our IT AI partners.
Fantastic. Andrew, please, let's hear about you.
Sure. Thanks, Jen. Thanks, Bill. My name is Andrew Yonke. I'm the CEO and founder and people person here at RainTech. RainTech provides fully and co-managed IT services, predominantly in and around cybersecurity and compliance in the co-managed space, and support and SaaS and cloud services pretty much across the board, and custom AI development.
Fantastic. And I know we have quite a few people in the room. So if they also want to introduce themselves kind of in that chat, so we can, as well, kind of meet everybody. So Bill, Andrew, welcome. Bill, I've had the pleasure and the honor. We've kind of worked together on some projects. And then you introduced me to Andrew and his team. It's really been fantastic. So thank you so much for having me. So really appreciate it. And this is a very interesting topic because, as you know, this is kind of a hot topic. We have, some rural health transformation money coming. HRSA and CMS has kind of discussed using technology and AI. It's a little bit of a newer topic. And I know we've had a couple of sessions that we're going to go through at the very end, kind of recap. But I know we've talked about with regards to AI strategy, structure, how do we use AI with clinical, right? Thinking about our patients and governance. So now we're going to kind of bring it all together, kind of like that package. We're putting it all together with a big bow is our health centers, how are we ready to adopt AI? So Bill, let me kind of turn to you've had, you worked in health centers, you have your team that has worked in health centers. I guess, how do we get started, right? So why do so many AI initiatives fail, especially sometimes in community health centers?
Well, I really think that AI initiatives, what we see, they fail not because of the technology itself, but it fails in the adoption. You need a strong strategy and strong leadership in adopting AI and prioritizing initiatives within the AI realm. We see a lot of organizations that try to start with a tool instead of starting really with what problem am I trying to solve? And so they treat AI just like a IT implementation of another product, when instead it really needs to be a leadership driven strategy. So that's really part of it. The second part is trust. And without the proper culture and leadership, staff is not going to trust the direction. And when the adoption happens, sometimes it dies quietly because you just don't have the culture and the buy-in.
It's a really good point. Well, and we're all afraid, right? I'm thinking about, remember when we implemented an EMR in our health centers? Remember GE centricity. That was a challenge. So absolutely. Andrew, from your perspective, because this is kind of your bread and butter, when you see AI really introduced, how is it that people aren't ready for it?
Well, I think that, again, just as Bill said, it really starts with the culture and the strategy. And what a lot of fears in the industry and without right now are that AI is going to replace people. And if you don't have a cultural strategy that nips that completely in the bud immediately, then you will likely run into extreme challenges in adopting AI. And if that is your strategy, if you are shooting for headcount reduction, I think your chances are extremely low. And that's because the people that you seek to replace are the very ones that actually are the humans that need to remain in the loop to still apply the judgment and authorize the decisions and the courses of action that an AI-driven workflow might seek to make.
Andrew, good point. So what you're saying is, when you hear it, that's the biggest fear then. People think that they're going to be replaced.
Yeah, and if you don't address that, and in fact, if your strategy doesn't start with, we are going to use AI to empower people and to better serve patients, then I think you're off on the wrong foot and probably not ready. If you're looking at it strictly as a financial utility to try to replace either people or some vendor or some process or something, and you're looking at it really small, and then AI starts popping up in your environment and you have not addressed the cultural aspect, then people are going to have those conversations themselves and amongst each other and start to wonder and ask, are we going to be replaced by this? And that's why if you don't have a cultural strategy around it, then you're leaving that an open question, and people will keep asking it, and that's just going to be a challenge.
Right. And especially right now, we don't want to have kind of that fear, right, into healthcare and workforce. So that's
It has to be the
Really good
opposite,
point.
honestly. I think that
Right.
success with AI in the FQHC space hinges explicitly on not just addressing these fears, but literally going to the other end of the spectrum and saying, this is how we are going to use this as leverage to be a more competitive place to work for clinicians and non-clinicians alike, for that matter.
Exactly. Well, and we always talk about, Andrew went right into kind of my next couple of questions, right? We always talk about, readiness. Are we ready? Readiness assessments. I feel like it's such a broad term, like we use it, a lot. So Bill, I'm kind of going to, turn to you. So when we say our organization or our health center is ready, what does that mean in real life, right? In practice? What does that
Well,
mean?
first it's the framing, right? It's
Um,
technology and
yeah.
AI are increasing on their capabilities at this exponential rate. And so the question isn't whether or not technology and AI can support what we want it to do. It's more whether your organization can actually support the AI and the initiatives and still be mission focused. So readiness really comes down to four keys in my mind. The first is leadership alignment. If you don't have leadership on board, you're going to have fragmented efforts and AI is being stood up in silos or just projects driving out or not being implemented. Culture and trust. I think Andrew covered that pretty well. If people are unsure and fearful, adoption will stall or it won't take place. But equally importantly, is governance and oversight. You have to mitigate risk. You have to maintain your responsibilities over your patient data and privacy, and make sure that there is the human in the loop, which I know we'll talk about later.
Right.
And then the fourth, obviously, is the operational workflows, because that's why we're introducing it to make our workflows better. And those workflows have to be stable, they have to be understood, and they have to be efficient on the starting point. Now, we can alter workflows and make them more efficient, but we have to have an idea of what we want those workflows to be in order to successfully say, hey, we're ready.
Right. So, Andrew, I'm going to kind of turn to you. So, Bill kind of framed it a little bit, but for you, Andrew, what are some of the signals, or how do you know that the workflow or the team is actually ready? What are we looking for?
Well, I think you hit the nail on the head when you said team. And this, again, with people being the entire purpose, certainly of an FQHC, but in my mind, even behind AI itself, certainly in the manner that we're talking about leveraging it, is really about leaning into having a valid cross-section of people in your entire ecosystem represented, so that people don't feel that decisions are being made without them and that these workflows are being sort of glossed over. If you have somebody in the C-suite or even somebody in middle management somewhere that says, hey, I think that there's a workflow down over here somewhere in this department that is ripe for, AI, but that user or that department hasn't really been involved in helping to delineate or articulate, here's what this workflow looks like today and how this workflow might be better automated, then they're probably not ready. So being ready, to me, means that you have stakeholders at the table, all of whom are ready to come with constructive and productive contributions to help flesh out what an AI strategy is going to look like for their individual department, or these are going to be your risk managers and IT representatives. So there will be people there, representing all aspects of the deployment. And so, to me, I think that you need to start with having those people and make sure that you've got proper stakeholder representation before you get started.
So, Andrew, you're saying have them at the table, essentially, right? Have
literally at the table.
And also, I like what you said, right? From the CEO to maybe facilities, patient support representative, I think, right? Kind of that cross department.
Yeah. And what else exemplifies that cultural statement that you're making than that, when you say, this is an amplifier and this is leverage and this is how we are going to empower ourselves as a health center, what spells that commitment out better than, and here is all the people who are at the table from day one. Not that these
Exactly.
conversations are happening in a back room somewhere and then sort of rolled out and handed off to everyone. It's like, nope, from day one, this is how we do this
Right.
together.
I appreciate that because now we're thinking, all right, we have these individuals, right? It's cross-departmental, so we call interdisciplinary. What about the messaging? Messaging across the health center. And remember, it's not just messaging internal. I'm thinking about, right, me as a patient. Now I'm a health center patient. So when we think about, we're thinking about messaging and communication. So what do you think, Bill? You work with a lot of health centers. You've worked in health centers. What's the biggest mistake when it comes to introducing AI to the teams?
So the first place I put myself is what you said. What if I'm the patient? And then the
Right.
second thing is, what if I'm a staff member, right? If a valuable
Oh.
part of this care team or this ecosystem that's a health center. And if somebody came to me and said, with your healthcare, we're going to introduce automation and cost reduction. Or I'm an employee and somebody says, we're going to introduce automation and cost reduction.
Right.
You've lost me out of the gate, right?
Right.
That's a threat to
And
my
you know what
role.
we're thinking, Bill? We're thinking, what's happening to my job? Right?
Exactly. Yeah. So it needs to be positioned as a support tool because that's what it needs to be. It needs to be this human amplifier, something that reduces burden and enhances
Right.
the ability for somebody to perform their job function and increase the quality of care or better the quality of care for the patient because that at the end of the day, that's our mission. That's what we're there for.
Exactly.
So, for AI to feel like a threat, adoption stops. But if it's
Good
supportive,
point.
which it's designed to do, the adoption is going to accelerate, especially when you have this cross-pollination across all the different aspects of running a health center together, working on an initiative. And then finally, for boards, they have to understand
Right.
it's about risk, it's about compliance, it's about sustainability, it's about quality of care. It's the same thing, not automation for the sake of automation. It's not coming out of the gate as a cost reducer.
Right. Bill, I'm also thinking, right, we think about HRSA compliance, right? How the board, I know we have those 5 policies, right, that HRSA says that the board has to approve. They also have to approve policies that, govern the overall health center operations. So, Bill, I'm thinking about, we also need to look at some policies. What do you
Oh,
think?
absolutely. There's a huge governance role here.
Right.
Your patients, you have their protected PHI, you have a responsibility to deliver quality care. Um, and you need to be ready with your policies, your guardrails, and have everything in place prior to adoption to protect the
point.
organization and the patient.
I like what you're saying. So we have to have, right, procedures, workflows in place, and then going kind of to implement it then. Interesting. So Andrew, I kind of turned to you, Bill has, shared he's worked in a health center, but then Andrew, what do you think about like the actual messaging? So what do we do? How does the messaging impact kind of adoption? Once we've deployed AI, what do we do with that?
Well, I think that it needs to be both grounded in, in reality and avoid hype, which, sort of outside of these circles, AI is highly subjective to a lot of hype.
Right.
However, I do think though that really leaning into what the human benefit is and what the purpose is. The purpose has to always be completely present in every decision that's being made, including how does this get communicated? Why are we doing this? Going back to that question of why. Well, the answer to why is not just because AI is out there and lots of people think that it can do a lot of things. It can very specifically do very mundane and monotonous and time consuming and repetitive tasks very well and very consistently. It can do parts of what humans do that typically they don't enjoy doing the most. They would rather be talking to a patient or
Right.
applying a greater level of cognitive ability that's closer to what their license or their training, would have them be doing, as opposed to, doing manual data entry back and forth in these clerical and administrative tasks, operating in between systems, for example, like, oh, well, this information is in the EMR and this one's in the accounting system or the ERP or this other third party site or whatever. So somebody's got to sit here and do this thing. And, or at least they used to have to do that. So that's what we want to focus on. Again, is we're not replacing people. We want to take some of the work off of them that they're currently doing, that is basically acting as the glue between existing systems that don't already perform this way natively.
Well, and Andrew, I'm happy you said that, right? Because when you look online, you know this, both you and Bill, you look online, sometimes that's not the message. And as health centers leaders, and even for whoever sees it, even, myself, it's challenging, right? You get this hype, myth that it can replace everybody. And
Well, that's a complete myth. And what's so funny is that the truth actually solves the fear once you sort of shift your perspective a little bit. The people who are pushing a narrative that AI can replace people are private equity investors and people moving billions upon billions of dollars around and wanting to see their 10x ROI on their investment.
Right.
And so for them, it's always headcount reduction. And that's why they're failing so miserably at doing it. But in reality, this is not really a problem or a threat. It's only a problem or a threat because of those people who put it out there as such and who declare it as such and who really, really want it to be that way and are finding, in various ways across the industry, how challenging that really is. Well, that's not what we're talking about. I do like to throw our company, RainTech, out as an example of a company who leveraged AI to move to 32-hour work weeks. It's like, hey, this is not like, oh, look, AI took all this human labor off the table, so I guess we need to go fire people. Do we? Do we need to fire people? Like, why would we fire people? No. How about we make life better for everyone that is now able to benefit from this? But again, we were able to do that because I was able to guarantee everyone that no one was going to lose their job. So everyone got to get really creative and innovative and really think, how can AI revolutionize the way that I do my work? And that's what they're all doing today. And so you can use it as this absolute leverage and catapult yourself forward and make all your people much more available for these, more cognitively challenging tasks or customer or patient facing tasks, as the situation may be. So this is really about getting rid of mundane, non-cognitively challenging, workflows primarily.
And it's people-centric, right? That's kind of what we're thinking about. So I think, Andrew and Bill, from what I'm hearing, right, if AI feels threatening, right, because it's scary, that's kind of when that adoption stops. But if we present it, and it should be in a supportive manner, then we can kind of move forward, right, and be a little bit more cohesive and, we're to the top of our licensure. So
it's an investment for sure. Now, again, I don't want to say necessarily that every CFO should anticipate that in the very long run that AI is not going to have some good potential impacts on cost structures, because it will. I mean, it definitely will do that because it is a lot more efficient at doing these, these mundane tasks like that. It's just not the goal right out of the gate per se, but it is an investment. The strategy itself, pulling the stakeholders together, forming a task force, is an investment in the workforce and the patients that says, we believe that this is going to make our people more available for our patients. And
exactly.
And that seems like something that every health center should really strive for in whatever manner presents itself that may lead to that potential. I think it definitely takes and makes sense to take a good look at it.
And in fact, Bill, Andrew went right into kind of my next question. So if I'm a CEO, I'm former CEOs listening today, maybe what are the 3 to 5 questions I should ask? Like, how do I know my health center is ready? Let's just pinpoint it.
Well, the first question is going to seem silly, but you'd be surprised.
Okay.
What problem are we actually trying to solve? And that goes back to, we're here to provide healthcare to these underserved communities.
Right.
And what problem are we trying to solve? And it can be an efficiency problem. It can be quality of care. It can be a number of things, but we have to ask that question. And then who owns it? Who owns AI? It's not an IT function, but who's the champion? And that really needs to be at the executive level, because without ownership, nothing moves forward. And we have to have a clear optic on the governance
Yep.
and visibility into risk, including the data flows, what are our compliance exposures, etc. The AI movement reminds me of remote monitoring of our patients or chronic care management when all of a sudden I woke up one day and there's 10,000 companies doing it. And one used to be a newspaper and one used to be a veterinarian.
Everyone gets into it, apparently.
Yep. So we have to be cognizant of our risk exposure there too. And then, are our workflows stable enough to support it? And then finally, do our people trust what we're about to introduce? And we have to get them to that point, or they need to bring themselves there through participation. And if you can't answer those questions clearly, you're probably not ready, and you have to work on those 5 things.
Well, I appreciate that because you kind of went through, if you think about it, right? Governance, operations, right? Finance, clinical, kind of those high levels. That's really appreciate that. So then, Andrew, you know what I'm thinking? So Bill kind of, we've been working in health centers, but then what about to execute it? I think because you're, helping to support this, but how can you tell when a health center is not ready?
Well, I think actually it's whether or not they're asking the questions that we're talking about right now. If they're asking intelligent questions and understanding the long-term implications, then that speaks to more readiness as opposed to, hey, we just rolled out GPT for half the organization because the CEO has been using it as a trusted confidant for a number of months now. And so
writing grants and writing all sorts of emails.
Exactly. People are going to end up using it anyway. And so the questions that I want to hear or want to see people thinking is, what are the levers? So like what decisions are in front of me here in terms of how we adopt AI? And what are the implications of them? So as we've talked about, and I think we'll review on one of the slides here from an earlier session, is about relationships. And are you choosing the AI that's bolted onto your EMR or to whatever system you get from somebody else? And is that vendor lock-in healthy and supportive of the rest of the long-term goals of the health center? And if you ever want to switch that vendor, but you're attached to the sort of the AI capability, is that challenging? And then more questions like, well, where does the data go? Right. Going to the governance question that Bill brought up is like, well, where is the actual information? And when we have to go manage that risk, which third parties are we dealing with? Because is it just the EMR? Is it just, ECW? Well, no, it turns out that, maybe their inference work, the actual AI work is outsourced, which is typical. I'm not saying that they do, but it's pretty typical because Microsoft and big hyperscalers are the ones that build out all the infrastructure that's useful for these things. So if it's not designed to live in and be within a health center's infrastructure, either their actual infrastructure within their facility or within their, say, Microsoft 365 and Azure tenancy, where it's fully isolated on its own, then that next question is, well, then it's going wherever these bolt-on vendors send it to. And now you've got to now manage risk for these extended, multi-length relationships that come out of them. And so asking those questions, I think, is smart.
Right. And so, Andrew, I have to tell you, right, a lot of health centers may be frontier or rural, and they'll be honest, right? They're not ready. So what would you say to a health center that's not ready yet, but they still want to implement this? Like, what's a start small kind of, idea?
I think that they're probably more ready than they think. And here's why. I think that most people are probably uncomfortable because of the technology side, and that maybe they're not as comfortable with that. But what they are certainly ready to do is to solve workforce shortage problems and to make work more sustainable, both for clinicians and non-clinicians within health centers. They're certainly ready to serve their patient population. So most importantly, all the motivation is already there. And that has to be the fire that's lit underneath any sort of readiness assessment or understanding. And so beyond that, I say, get people together, get a good cross-section, make sure that leadership is is thoroughly bought in and driving this. It's not something that really ought to be just handed off or sub-departmentalized under somewhere else. And then start coming up with your policies. Obviously, as we said, the policies, the guardrails, everything's got to be in place so that you can start to deploy this. But things actually move relatively quickly with AI too. So it doesn't mean that this is going to be like in a year we'll have AI. It's like, no, I mean, in a couple months, you can probably start to safely deploy AI solutions that are customized for your health center. So that's a more reasonable, time frame. But I think getting those people together and saying, first of all, we need to take what we already know with HIPAA and HRSA and all of the regulatory requirements, which again, health centers are already super, comfortable with, or
we're highly right. We're
highly used to. Exactly. So I think that they're a lot more ready on that front even than they would think. They do need to ask more critical questions though about like, okay, where does the data go? If the data that lives in the EMR is just in the EMR. And if the EMR vendor is also doing their own inference work on their own infrastructure, then it might not be going any further than that. But you have to know. You have to know where that data is being sent off. And so those are the questions that need to be asked up front.
So Andrew, because this kind of goes right into I had, our next section, but can we specifically, what's a good first pilot? We're kind of ready, right? We did our readiness assessment. How do we start? Do you have some examples of some, simple pilots we could try?
Sure. There's lots of opportunities in revenue cycle management. For example, revenue cycle.
Love it.
And so in an earlier session, I think we had broke down as many as 8 or 9 or something different sort of potential agentic workflows that could be associated with this, because you've got everything from upfront patient engagement and communications and scheduling all the way to the back end claims processing and submission and adjudication and all of that. And so there's a number of different functions in there, and they vary widely, even state by state, and particularly in FQHCs that rely so much on Medicare and Medicaid. And there are state level nuances that exist there that in some states require a lot more manual work, for example, to do insurance verification, for example. So that might be one where you say this is something that takes a lot of our time. Another might be a patient contact center. So this might be an ability for patients to text or to talk, to an agent about the things that the health center is comfortable putting within that kind of a platform. And again, this is what these stakeholders all get around together and decide. And I know that a lot of people have questions and they need to be asking them. Ultimately, though, the decision, the empowerment is going to be, as it always has been, within the health center itself. And so they're going to decide, are people going to be comfortable talking to an AI? Well, I don't know. They're pretty advanced. Can we try it? Sure. Why don't we try it? Why don't we test it internally? Hey, can somebody call a number? And it's not all right, we're going to pull the trigger on this. Everybody hold on. It's hey, what would this sound like? Well, it turns out what if we did it after hours? And we could definitely have at least 24/7 coverage for an agent to answer basic health questions or whatever with really, really firm, guardrails around exactly what it can say and what sort of advice it can give. It's effectively like an interactive FAQ in that regard in one way. And it's that might be a way. Somebody might say, gosh, our people are getting killed on inbound phone calls. Or they might be saying a lot of patients are saying that they really want to text with us or just have questions about their schedule, or they want to change an appointment or whatever. They just want an easier way to interact with us. On their time, on their schedule. It might be 11 o'clock at night. They're laying there awake, wondering, if they're going to be able to make that appointment or if they should reschedule it. And so there are lots of applications like that where you can say, let's bite off a slice here that says this is, as Bill said, a relatively low risk, but high return. We know we're spending a lot of time on this. And we know that sort of the decisions, if you will, the reasoning, if you will, being utilized by the AI is relatively narrow. And we highly recommend that. It's not that you sort of start up an agent and say, run my health center. It's more you tell this particular agent to check these 3 sources for any one of these 4 or 5 pieces of information that has to look exactly like this. Period. That's it. And it's that's all it's deciding between. And that's when people talk about the fears with the black box and what is the AI doing.
Right.
All of that reasoning needs to be recorded. That's baked into some state level regulations. The federal government is trying to prohibit states from regulating AI, but it's already in a number of states. That's here in Colorado, for example. You have to be able to show the chain of thought, the reasoning that every agent took on anything that it did. It's like, yep, I checked this API and the patient exists here and here, but this policy seems newer. So I said, this is probably the active policy that, that this patient has and what that we need to verify. So that's the kind of little decision that we,
stuff.
it's not go solve the world's problems and figure out how we're going to be the best health center in the world. These are programs that are written by software engineers that have very thin slices of these AI capabilities that are very, very narrowly focused on the exact function that particular agent is designed to perform.
Let me ask Bill. So Bill, you've heard what Andrew said, kind of picking, right? Small pilots. How do you feel about that as a health center leader, as a CEO, CFO? What do you think about these pilots? You think they can work?
The pilots, well, let's take a step back. So we're saying that we've gotten to the point of readiness. And the important thing I want to emphasize there, we have not convoluted interest with readiness, which a lot of folks do. I'm interested in AI. Yeah. I'm interested in building a small off-the-grid cabin. I'm not ready to do it. So, once you're at this point, by starting with the small, visible, low-risk initiatives, you're building trust with your team. They're trust-building exercises. They're not just an implementation. It's not an experiment or a test of the technology. It's a test of your organization's ability to adopt change and adopt AI. And you always need that human oversight and clear accountability. But these pilots need to be not only risk averse, but they need to be measurable. They have to have clear value.
Right.
And almost most importantly, they need to directly support staff in order to build that trust.
Great. Bill, you know what I'm thinking too, right? As health centers, we're always piloting things, right? Think about our PDSA cycles, right? In quality. This could maybe sit in the QI committee or, where we're looking at piloting to see if it works. And then we can kind of, roll it out.
Absolutely.
Yeah.
And we've talked about that, I think, in a previous session.
Yeah. I don't disagree. But here's kind of what I'm concerned, because look, Andrew, Bill, you know this. Sometimes we go into organizations and health centers where, I'm going to be honest, working in health centers, I don't want to do this. Nope, I'm resistant. So as you know, sometimes there's resistance to change because it's not only scary, but we're changing workflows that we've known, right, for many years. So Bill, what should leaders expect? So when they're introducing AI, we know that there's resistance. What would be the next steps?
Well, first, the important point, and I think a lot of people know that resistance isn't people saying no. It's people not using the tool, following the procedure. I mean, in health centers, how often have we seen workarounds or skepticism behind the scenes with change or not fully adopting something the way that we want to adopt it? But organizations that manage this well from the beginning with early staff involvement, clear communication, discussion about guardrails, and equally important, investing in the training and understanding for your staff. The training is a big piece of this so they understand these tools and how to use them. And at the end of the day, it's, again, not a technology rollout. You're talking about transforming your organization. It's not about resisting AI. It's about resisting the uncertainty with those things that we also talked about. Is my job at stake? How is this going to affect patient care, et cetera?
Right. And understanding the why, Bill. That's what I'm thinking, right? Like, how it's an onion. We're trying to peel it back.
Yes.
I think that's really important. So then, Andrew, we so from a leadership, but what about how does resistance show up in day-to-day operations? What do we do with that?
I think like Bill said, in the IT world, We actually have
Yeah.
a saying that says that there's nothing more permanent than a temporary workaround.
I
um,
like that.
and so yes, it's once let's say you've met the cultural requirement and you've communicated effectively about not replacing
Right.
people and alleviated people's fears and at least started to get people thinking frankly positively. We're still working against a
Right.
negative impression on something that actually just has nothing but, well, not nothing, but when it properly deployed and adopted has a
Right.
ton of upside potential that we really want to get people excited about, because it's more like everyone's sort of looking at this like a necessary evil almost. And it's like, by no means, it's not necessary at all. Don't use it at all if you don't want to use it. Frankly, like
Right.
you don't have to use it at all. It just has a ton of potential to save a lot of time on non-mission critical tasks, which should free you up to be able to perform more mission critical tasks.
Right.
And I think that's what, what we want to have people be oriented toward.
Andrew, do you think I'm thinking about, remember when we had the pandemic, we remember telehealth? It was kind of, everyone was afraid of it. Remember all of a sudden within 24 hours, our health centers had telehealth services.
There you go. I mean, because you had no choice. And then suddenly now everybody wants it too. Now you're like, I need to go to the doctor. You need to go somewhere to see the doctor. Yeah, just like working from home, right? Like that used to be, that never happens. And now it's, it's on every single employment negotiating table anywhere practically is that question coming up. So yes, is there some level of inevitability here? Sort of, because you can look at an agentic and AI driven workflow the same way you would an EMR. It's sort of automating, certain things that used to be a lot more time intensive. Really, at the end of the day, that's it. But it's just a computer doing what a human told it to do.
Right. I love that. I was just thinking, it just popped into my head, that whole analogy, right? Like it was just, we were so afraid of it.
Yeah, we didn't have any adoption around that right up until COVID. And then all of a sudden, with the comfort level just went through the roof. And so it might look it will look something like that, but I think it's going to look like that more for organizations like RainTech, for example, who have decided to use AI as, leverage and a way to empower our people and to make us a way more competitive place to work. I don't know how many IT companies you're aware of that have 32-hour work weeks and unlimited PTO, let alone being 100% employee owned. But that's sort of like beside the point. But the 32-hour work week is very much coupled with and enabled by our innovation with AI and how our people have been able to use it to automate a whole bunch of the tasks that they typically do that are much more time consuming. So, there you go. There's an example of it working right there. If you simply establish that as your purpose is serving your staff who are serving your patients, then I think you're setting yourself up for success. But if you're trying to dodge the elephant in the room and not talk about what you're actually trying to do with AI, then that's obvious, because humans aren't that dumb. And even if they don't know exactly what it is that you're thinking while you're talking, they can tell that something else is going on and they're not going to trust you, as Bill was talking about.
Absolutely. And I think just to kind of sum this up, right, it's really organizational transformation. It's health center transformation. It's not like a technology rollout. So
I agree. It's got immense implications across the board. When you're talking about the hours of staff and all of that, like it has tons of implications, which is why you need an organization-wide task force to say, what does this mean for us? And how do we leverage this to serve our patients to the very best of our ability?
I agree. So glad you said that. I feel like for Andrew, Bill, this has been such, a robust discussion. I think really important that needs to be had. And I want to kind of transition and turn it, making sure that the audience, our team here has a chance. So if they want to ask Q&A, please put your questions or even your comments in the chat, and we will ask Andrew and Bill. So feel free to chat if you have any comments about today, or Q&A. Happy to ask questions. If you have a scenario you want to throw out to Bill and Andrew, happy to hear them. So while we're waiting for the audience to kind of, put their questions in the chat if they have any, I actually have a couple personal questions if that helps. So for Andrew and Bill, I think one of the main concerns I have, Bill, we want to deliver, high quality healthcare, culturally appropriate. So with AI, how do we decrease that inherent bias in AI? Andrew, Bill, I don't know. Bill, do you want to take it? And Andrew, I'm happy to hear what your thoughts are.
Yeah, so it's, as health centers, we are to deliver culturally appropriate care to those that we serve. And so the first step is being aware that there are biases out there with data once we're pulling stuff in from the outside, and depending on the demographics of the population we serve and a number of other factors. So our systems need to be designed around accounting for those biases. And I think Andrew, from a technical standpoint, can probably say the how. Certainly,
I can tell you what the how not
exists.
I can tell you what the how not is also, and that's asking technologists to fully understand that bias and craft the mitigation for it. Now, the mitigation for it is very technically sort of understandable. It's instructions. You give instructions to these agents that are very good at following instructions very consistently every time. But what factors or parameters or what behaviors need to be influenced and how, that goes directly back to the FQHC space itself. If I were sitting here telling them how to communicate to their patients, or by extension saying, here's how to tell AI how to communicate with your patients or your staff, for example, then I'm already putting myself into a position as though I know something that truthfully I don't. The better question is, when you're embarking down this path, you as an organization have to say, how are we going to address the biases that exist here? Then work with your partners. So whether you're working with a RainTech who's building you a custom AI, platform or solution, or you're working with somebody who's bolting it on, whatever it is, you need to find out what are the levers available to us to craft or influence the behaviors of the workflows that are happening here. We need to adjust their communication style, or we need to adjust this, that, or the other thing. And again, how to adjust all those is actually pretty straightforward. The actual adjustments to be made, I think, need to be gleaned through both the existing inherent knowledge that every FQHC has about its patient demographics and its staff and all of that, combined with some testing and actual just usage in a test bed, just a proof of concept, like, oh, okay, I called in, this is the conversation, I think it could have gone a little differently, or I would have preferred that they offered this, or that, or whatever that is. And we go, great. And then we go and we tell the agent, hey, make sure that every time you do this, or make sure that every time a patient says X, that you do Y, that sort of thing. And you just bake that right into the logic that these agents execute every single time that they're sort of in bubble.
Good point. So then I'm just curious, because, I'm always a curious individual. Bill, and Bill, you go first. Where's the most resistance? Clinicians, staff, or leadership?
Believe it or not, I think clinicians are pretty high on the list of being aware of the capabilities of AI, because there's so much information out there for them, and they're reading about it, and they're seeing it through their continuing education.
Right.
I think the resistance is really staff, and it comes down to messaging and fear of their job, right? It comes down to fear. And is AI going to replace me? And I think it's the staff, the front end staff, call center staff. Those are the folks that are looking at this and saying, is my job at stake?
What's funny? I was just about to say the same on the other side, because you absolutely have half the people are afraid that I'm going to lose my job to AI. And then on the other half, you have your senior IT and cybersecurity and executives who are unclear, maybe as of yet, exactly how to fully secure these AI driven workloads. And so they're afraid they're going to lose their job because AI causes some sort of big security breach. Not that it's going to take their job, but because they're going to be presiding over this disaster that AI came in and tried to take over the world on their dime, which is, I joke about that when I'm delivering these workshops to PCA and things like that. It is, but I have to kind of bring it up. It's so weird delivering these workshops because it's so strange that I have slides with pictures of like Terminator and we actually have to talk about that. Like here we are in, a big PCA conference, like, hey, everyone, we need to talk about what AI is and what it's not. And as long as we're just sitting around looking at cherry picked information coming from research labs that have carefully crafted circumstances that allow an AI to do something that they didn't expect it to do, that is a very, very, very different thing than what happens in production environments and what happens in enterprise deployments.
Well, and Andrew, you know this. We have so many movies out there, right?
I have a slide with pictures of like all of them. There's the Terminator and Data from Star Trek, and I grabbed all the robots and AI I could, and but there's the seed of truth that's if anyone's curious and they want to know, well, why does AI do weird things? It's because that's what it was trained on. It's trained on human generated content, which is not just novels, by American classic authors. It's everything. Right. It's everything from pop culture to science to all of it. So all the AI models are trained on popular culture information stemming from and out of Terminator and The Matrix and all these movies around AI. And so, of course, it has a general conception of what AI will do. And so it's not a stretch to know that when you put it in a lab and you give it the right conditions, then it's going to do this thing that it did in the movies. And it's like, well, why do you think it does that? It was trained on the movies, but that's not the same as what we're talking about. It's
that education piece, I think, right? I think this is the whole, I don't know, the takeaway message, I would say, right? It's all about, right, people-centric, but it's also that education piece you're talking about.
For sure. And we're not talking about Terminator.
No, we're not. And here's the thing, when we don't know as humans, right, when we're afraid of things we don't know. And I like that you and Bill you've done these educational sessions. In fact, we're going to transition, kind of see what you've done the past couple sessions to kind of dispel the fear and also what you can do with AI. I think that's pretty amazing. And so kind of I think this is our session, right, that we just did.
This is the last one. This was session 4. We're on session 5.
That's right. Thank you. So last session you talked about, right, infrastructure. I like your regulatory guardrails, right? You just talked about so it doesn't go Terminator on us, right? Really thinking about what safe AI looks like. And it's not the adoption. It's, you know what I mean? It's, if you're implementing something, you have to have oversight, right? And I think don't you think that's kind of the takeaway? Bill, what are your thoughts about last session?
Yeah, I mean, that's it. You need to create an environment that AI can grow in that has guardrails. This is something that we need the guardrails. And most importantly, we're dealing with humans and human life. We need humans in the loop. Right. That's, as it says here, the non-negotiable. Yeah. So those are really my takeaways from last session.
I want to rename that.
Yeah.
Sorry, I want to rename human in the loop, and I don't know exactly what it is, but
yeah,
I feel like we're sort of overemphasizing the loop as the important thing there, and this is the de facto standard language for this. There isn't another thing for it, but it still sort of makes the human seem like the afterthought that we've sort of just pushed back into the loop. But everyone needs to realize that these loops do not run without humans. They are they're just not intelligent, and they can't manage themselves, and they can't improve themselves. And they're really good when they do very well-defined narrow tasks and have proper human oversight. And it changes the humans' work from spending 3 hours this morning manually moving all of this information between all these different systems to I spent 5 minutes this morning reading the summary of what was proposed to be moved, verifying that everything was exactly the way that I would do it if I were doing it manually, and going, yes, click. And that's it. And that's what this looks like, different from yesterday versus today. The human still has to review that, though, and know that everything being submitted is actually what's supposed to be submitted. And when they click yes, go, just so they know from a regulatory standpoint, it is not, well, then some nameless agent over here did this thing. No, it is that Kathy authorized this information to be moved from here to over there. The AI work has already been done at that point. The AI, what little reasoning we've allowed it to do in any given workflow, this is what it's now come up with. It's like, here's my plan. This is what I think I should do. Everything from there is strictly deterministic. It's just, I'm going to move data A from, location 1 to location 2 or whatever it's going to do. And the human needs to look at all that reasoning and go, that's exactly what I would have done. Yes.
Right.
And,
so that was that session. It was a great session. And then, as you know, this is kind of one of my favorites because I do have a clinical background. I know Dr. Roberts and Anna Ferguson kind of talked a little bit about this because this is a fear too, right? Bill and Andrew, where there's a fear that AI is going to diagnose, treat, and prescribe, right, and see our patients. But it's not. That's not the purpose. It supports, right, the clinical care. It does not replace providers. Doesn't replace, right, behavioral health, primary care, medical, dental. I say the whole gamma, right? It just kind of supports individuals or providers to practice to the top of their licensure, right? It helps inform decisions, but it should not make them. So
I think it's an extra set of eyes, maybe, but I'm not personally aware of anyone out there that's marching all the way out to the end of these limbs. Now, that's not to say that they're not there. I could probably go find some that I think that are going a lot farther than they should. But honestly, nobody's got any business whatsoever trying to tell an AI to perform and commit diagnosis and prescriptions and things like that. That's just not.
We hope. We
so a lot of this is around perception too. So if Bill Franz goes out and goes onto ChatGTP and says, "Do I have malaria or the flu?" Okay, that's something that I do, but I can interpret that without knowing what's around me. That that's what they're talking about it with AI in healthcare. Is that now the system is going to do that same thing in the physician office. So part of this focus on not replacing clinical judgment is the education with the patient.
Right.
For sure.
Good point. And then kind of, we're winding down. So I'm looking at the time here, thinking about, AI and, revenue cycle. We talked a little about, I think, Andrew, this is where you talked about, if we wanted to start with our tasks, it was, financial sustainability, revenue cycle, operations. So kind of really thinking about that and how do we use those tools, to be a higher functioning health center. Right?
Yeah, this is to get people to think about the range of potentials that's maybe outside of the clinical ones that they might be hearing quite a bit from their EMR vendor from. There's just opportunities across the board.
Absolutely. And then I love, this is kind of my favorite here. I know you all started with this, is I always start with human centric, right? Yes, it's AI, but really making sure at the end of the day, it's AI supporting the workforce that we have, right? Really thinking about how do we integrate that? We're not trying to, like you said, Andrew, we're not replacing humans. It's how do we kind of work together to be that, high functioning health center. So
I think when I see human centric, it also makes me think of almost like the human in the loop and the implication that there's something else apart from humans going on here. And it's like, honestly, that's a bit of a lie. And as Bill points out, sometimes we have an ethos here at RainTech called people, period. And it's because we don't put people first. And it's because if you're putting people on a list with anything else, your values might be a little bit out of whack. It's people, period. Exactly. Same with this. We call it human centric, but all that's sort of implying that there's anything else here of value apart from humans.
Absolutely.
And the important thing within a health center is we described it as an ecosystem. And
Exactly.
that is why we need to empower everybody in the organization through these initiatives. It's not just about the clinician, and certainly it isn't about the finance area for sure. That's almost an afterthought to a certain extent. But we need to empower people. We need to involve them, and we need them to become the champions, and not just have it be a top-down directive.
Great point. Well, Andrew, Bill, this has been absolutely such a fantastic experience. So happy to help, moderate. I think a lot of health centers want to get started. So Bill and Andrew, is it okay if they reach out to both of you? I think you'll be fine with that.
Absolutely.
Perfect.
Absolutely.
And then I know Jessica just put, we want to hear your feedback. We also have a QR code. These sessions are recorded. People that have joined, they're going to get the links, right, within a week. And then Andrew, you said that the rest of the sessions, right, are on your website, as does Bill, right? Both of you.
Correct.
Both. Yep.
Okay, perfect. And then, if participants have other ideas for Bill and Andrew, right, to hear about what other things you want to hear about when it comes to health centers, AI, whatever, maybe some other educational series. Is Bill, Andrew, is that okay if they reach out?
We'd love to hear it. Absolutely.
That would be terrific.
Absolutely. Thank you so much, everyone. Please fill out the survey. I hope everyone has a great day. Good morning, good afternoon, and thank you so much for joining us today.
Thanks, everyone.
Thanks, everyone.
Bye.